members of society. There's 30 of them, and they roughly represent the demographic of the UK in terms of age and gender, disability, ethnicity. And we ask the council, they operate a deliberative democracy approach, and they are there for when we as an organisation are struggling with a moral or an ethical dilemma, and we want the perspective of members of society. We were having a conversation at dinner last night about the use of incentives, and incentives is one of those things that we've asked the council to look at. It's an area where there is a lot of evidence that says incentives for things like losing weight or stopping taking drugs are hugely effective, but they are troubling from a moral point of view as far as society is concerned. And so it was very important that we present that kind of question to our snapshot of society to say, this works really well, but is it acceptable? And so, as I said, I haven't done a separate slide about the council, but I'd be more than happy to talk about that in more detail. But it sits alongside the way we involve patients and the public in specific topics. It's very much about advice to the organisation in general about these moral or ethical questions. So, what is it that we think that patients and carers are bringing to what we do? I'm sure this is all fairly self-evident, but I think it does bear some repeating. The very first thing and the most obvious thing is what they bring is knowledge about the personal impact on them and their lives of what it's like to live with a disease, a disability, or a condition. As I indicated earlier, they can also tell us about the outcomes that they're looking to achieve and helping us identify whether those are the things that have been researched, those are the things that clinicians accept are the important outcomes, but they're very much there to make sure that we take account of what's important to them. They can also tell us about not just the impact of their condition, but the impact of any treatment on their outcomes, on their symptoms, on their physical and social functioning, and also on their quality of life. And also the impact of both disease and treatment on their family and their friends and their employers. They can tell us really practical things about if we're recommending a particular drug treatment or a particular intervention, how easy it is for them to take, how easy it is for them to use. If it's something they have to inject themselves, is that something we should be taking into account? They can also tell us about the side effects that, again, may not be in the published research. Really crucially, they can tell us about what their preferences are. We can say, this is what the evidence says is best practice, but if that's something that people find unacceptable or intolerable, then we have to take account of their values and their preferences. I talked at the beginning about our obligations to take into account particular groups in society who are either more adversely affected by a condition or have problems with accessing treatment. And the patients and carers and the organisations who represent them can help us to identify what some of those issues are. I talked before about challenges. These are really important. Making assumptions is often something that health professionals or researchers do, both about the impact of a disease or the impact of treatment. And so it's important that those assumptions are subject to challenge. And I will give some examples later in my presentation about where those challenges have resulted in changes to the recommendations. And very, very crucially, one of the things that everybody who's involved with evidence-based healthcare comes up against is that while you're looking for the evidence to try and answer your questions, you come across huge gaps. You find areas that simply haven't been researched but are very clinically important. And so the patients can help us identify what areas, from their perspective, might need further research. And we have a mechanism at NICE where we identify where these gaps in research are. We have a link with the research funders. And so there is a way of us saying, well, this is an area that needs researching, and the people with the money can say, okay, well, we will fund a research project in that area. But the final point on the slide that I wanted to make is that it's the evidence that, and the information that we get from patients and their carers is most useful when presented in a way that balances both the positive and negative aspects. Again, there is an assumption sometimes that all patients want access to all new drugs, and it's really important when people are talking to us about their experiences that they tell us what's good and what's bad about the treatment that they've experienced. So I want to talk a little bit about how we identify the patients and carers who sit on our groups. As I've said, we have a minimum of 2 patients or carers on each of our development groups, and we offer to pay them. We offer to pay their expenses, but we also give them money for coming to meetings. We pay them 150 UK pounds, which I guess is 175 euros, something like that, for each full day meeting that they come to. They don't have to take the money if they don't want to, and many of them choose to have the money go to a patient organisation instead. But we offer them the money because we acknowledge that for the health professionals, being on a group like this is part of their professional development, and they are allowed by their organisations to take part. But often the patients have to take holidays in order to come to a meeting, or they have to stop manning a telephone line or something like that. So we acknowledge that we have to recompense them in some way, and we think it's appropriate to offer them a payment. We have an open and transparent recruitment process. All of the vacancies for all new groups are advertised on our website. And we also contact all the relevant organisations to let them know through their networks that we're recruiting people. And anybody who has an interest can apply. They don't need formal educational qualifications, and nor do they have to have an association with a patient organisation. They can just be Mrs. Smith, who happens to have multiple sclerosis and would like to help us develop this guidance. And since we moved to this open and transparent recruitment process, the quality and the quantity of applications that we receive has increased enormously. And so by keeping it this open, I think we get an interesting and varied range of people applying. And it's very helpful for us to be able to recruit people from a wide pool of applicants. So in order to make sure people are aware of what it is they're applying for, we have a very formal job description and person specification, as if you were applying for employment. It's that kind of detailed about the nature of the work that's involved and the kind of skills and experience that we're looking for from our lay members. So people are asked to complete a pro forma when they apply. And they're also asked to complete some equality data monitoring, and we ask them to sign a conflict of interest form because we have to be absolutely scrupulous at NICE about making sure that anyone who works with us developing our guidance is completely independent of any influence from the pharmaceutical industry. And so if somebody is employed by a pharmaceutical company or used to be and has a pension with them or something like that, then that could be a potential conflict, and we would need to take that into account when recruiting them. What we have found works best in terms of recruiting people is a combination of patients and carers and people who come from patient organisations, because it brings a much rounder perspective than if we just had patients, just had carers, or just had people from patient organisations. So the kind of things that would be on our person specification if we were advertising is a clear statement that no formal educational qualifications are needed to join the group. Though in some recent analysis that we did, we found that 2/3 of the people, of the patients and carers who sat in our groups had university-level education, and the greatest proportion of people, around 39%, had postgraduate qualifications. So it's kind of the reverse of the population graph for educational attainment, but we do stress that it's not a necessary part of applying. But I think something about the nature of the work, something about the kind of people who are interested, it tends to mean that we get very highly educated people applying. We're looking for people who've either got direct experience of a particular condition or indirect experience, whether that's as a carer or as somebody who works for a patient organisation. So it's that combination of breadth of experience that someone from a patient group would bring and the depth of experience that an individual patient or a carer would bring. But we also need people to come to the group with an understanding of the views of a wider network of patients, and which is why being perhaps associated with a patient group can be very helpful, even if they're not employed by them. When I talk about what some of the problems are later, I'll speak about this in more detail. But there is, we need to make sure that we don't get people who perhaps have had one really bad experience and that's all they want to talk about. We want people to bring their personal experiences, good and bad, but we need them to be able to think about patients in a more general sense. At a very practical level, we need people who have the time to commit to attending these group meetings. And they may be a meeting a month for 18 months, which is quite a lot of time to commit. And also there's an expectation that there will be reading in between meetings as well. So we need to make sure that, and again, it's another reason why we offer a payment to people, is that we're very well aware of the commitment that we're asking from people. Ideally, we want people who've got some familiarity with medical language, and we find that most people, particularly people with a long-term or a chronic condition, are very familiar with the medical language about their own condition. Research language, the language of guideline development methodology, is something that very, very few people know about. And so that's a lot of what we do, is try and support people in that. And there is an expectation that the technical people on the group, the people who do the systematic reviews and the searching, will help people with that understanding. But obviously it's an advantage if they come to us with that knowledge. We really need people who've got good communication and team working skills. These are small groups of perhaps 12 people, and so people need to be able to work really well as a group. And we have to be very clear that people are there to represent not an organisation, not one particular point of view, but to just bring their experience. So in terms of supporting the patients and carers who work with us, that's largely the responsibility of my team. And we have 3 key functions. The first is at quite a strategic level, is to advise the organisation, to advise NICE and its board on the methodologies for involving patients, carers and the public. At a kind of a slightly lower level than that, we are also responsible for trying to identify as broad a range of organisations who can work with us. And that's a huge part of what we do. And we now have a database of around 1,800 organisations that have worked with us to a greater or a lesser extent over the years. And we're constantly refining and updating that to make sure that as new groups emerge, that we can take account of them and make sure that they have the opportunities to work with us if they wish to do so. But the most important, I think the most important, and also the most intensive and most detailed part of what we do is the information, training and support that we offer to the patients and the lay people who engage with us, whether that's as individuals or organisations. And for example, everybody who joins a guideline development group as a patient member has a named member of my team who is there to support them throughout the time on the group. And so that they know that if there's a problem, there's someone at the end of the phone, or they can drop an email to somebody and say, can we have a quick conversation about